Hi. Good evening to everybody who is on the Indian subcontinent, and good morning to people who are joining us from the States and Europe. Probably not Europe, and probably it's afternoon in Europe, so yes. First of all, I must thank you, ladies and gentlemen, who have joined us this evening. On behalf of the IAGES, which is the Indian Association of Gastroendosurgeons, the organization which is doing this seminar, this webinar, I thank you for joining me in this webinar. I must say there has been no dearth of webinars in recent times. It's in fact ironically assumed an epidemic proportion in itself. So a special thanks once again to those who have joined us. I hope and I'm almost certain with the kind of learned panelists, and not only panelists, they are visionaries. We hope, and I am sure we'll not disappoint you. Well, there have been some crazy things that have happened in our lifetime. We witnessed the moon landing, the color televisions, internet, social media, Google, smartphones, trade wars, regional wars, nuclear threats, antibiotic resistance, recessions, and viral influenzas. But I think we all agree that we have never witnessed something as extraordinary as this. The coronavirus is derived from the Latin word meaning crown, and has really made man to almost submit itself to the virus. Now you may be seeing why we wrote down with the crown. It threatens to cull and impose a massive loss to mankind, but human species also known to be amazingly resilient and adaptable, and has survived plenty of scares in the past, and human spirit is indomitable. And therefore we humans believe that this too shall pass. And therefore, in this era of coronavirus, I'm an extremely knowledgeable and far-sighted experts with indomitable spirits who will shed light how to push forwards in these trying times and take the crown back. And that's why the title, ladies and gentlemen, Down with the Crown, Pushing Forward. Now, it's my absolute honor to introduce these names to you. The first one of the most respected names in our country, and the director of Max Surgery Specialty, New Delhi, Dr. Pradeep Chaubey. I am also honored to introduce one of the most leading names in USA and the chairman of Carolina Specialty Surgery Center, Dr. Todd Hanniford. It's a privilege to have Dr. Neil Smart, consultant colorectal surgeon at Royal Devon and NHS Trust. Dr. Abhishek Kumar, an expert pulmonologist and critical care from Iowa, USA, Mercy Hospital. And Dr. Anuradha Agarwal, our own expert microbiologist from our institute, Bellevue Hospital, Kolkata in India. And before we begin this webinar, I would like to hand over to our dynamic president, Dr. Raman Goyal, who has been absolutely amazing in his approach towards this crisis. Right from the very day one, he was on the top of it. He was collecting the data. He was talking about it. He had meetings. And I think words of wisdom from him at this moment would lay a good foundation of what is to follow. Dr. Raman Goyal, sir.
Hi, good evening, everyone. Welcome to all the panelists who are joining this. It's an honor to have you all. Dr. Pradeep Chaubey, who is not only the past president, but also an advisor to IAGES trustee, and all our guests from overseas, Dr. Anuradha Agarwal from Kolkata, welcome. IAGES is a 27-year-old organization. We started in 1993, and we have about 8,000 laparoscopic surgeons, the largest body of laparoscopic surgeons in India. And this is primarily an academic organization. So we do about 22 training programs across the country every year. And this is a retraining and recertification organization for laparoscopic surgeons or those who are starting laparoscopic surgery. And then as I am a pediatric surgeon, my practice came to a standstill when Corona hit us. So I thought this is a good way to utilize my time to keep busy and to help people who are really fighting the war. So what we did about 3 to 4 weeks back, we held an emergency executive committee meeting And we got this approved that for the duration of COVID, we turn into a service organization. So we have initiated a IAGES COVID task force, which not only does webinars like this, but it collects money and donates actual PPEs to government hospitals fighting this COVID war. And we have been able to raise a substantial amount and donate these PPEs across the country, whether it's Tamil Nadu, Bengal, Delhi, or Jaipur or Mumbai, large number of them. And this is an ongoing task. And now social organizations like Rotary are joining with us to fund this and to get this delivered. Our strength is that we are in every city, we are in every hospital. So we are able to reach out directly where it's required. And we have time because we are our elective work has stopped practically. So this was one. And then these webinars. The webinars, we are holding two type of webinars. One is a subject specific webinars, which are held every Friday. So we did for how the gallbladder surgery should be done, hernia surgery should be done, endoscopy should be done. And the next webinar that's coming is a oncology webinar coming Friday. And then we have these webinars on Sunday evening, which are for the medical community in general, which includes surgeons, physicians, family physicians. So it's more of an educational webinar. How do we practice in this time? Besides these, IAGES was the first to come out with surgical practice guidelines for all the surgeons in this country, which was about 8-9 days back. And already these are being updated. We also took the initiative to start inter-association guidelines. So we have 3 associations in this country, and those guidelines should be ready, I think, by Tuesday at the most. So I think there are a lot of things happening, and it's always a good thing that we, and as far as Sarfraz is concerned and webinars, I don't think that it's an epidemic of webinar. We need many more to reach out to lakhs of doctors in this country. I'm sure not more than 50% doctors have still seen even one webinar till date. So I think this has to continue, education has to continue. And I leave it to Dr. Sarfraz Beg, who is a leading surgeon from Kolkata, to take charge of the webinar now onwards. Thank you.
Thank you very much. So let's begin right away. Well, very frankly, it's not the first time that a flu has affected the human race. It struck us in 1918, that's about 100 years back, and wiped out about 10% of the world's population. It took 2 years for the flu to subside with 2 more waves in between. So this is one knowledge that we need to have. The medical community who's just watching this and who is uncertain about what is going to happen next needs to know this data. Thereafter, we've had SARS, MERS outbreaks. We have now COVID-19. So flu is not new. It's our reality. It's our present. It may be our future. History is replete with these events, and we need to only pay attention to learn from them. People did survive the scare 100 years back, and with our present resources, technology, especially in communication and diagnostics, and brilliant minds, I'm sure we'll all survive this too. But in the process, even back then, plenty of doctors and staff and nurses lost their lives. The idea of this webinar, therefore, ladies and gentlemen, is to create awareness how a doctor can safeguard himself or herself in this pandemic while providing healthcare, and to see the world of a doctor through a COVID prism. We know we're going to practice differently, but the idea is to see how we can do this safely. The aim of this discussion is definitely not to look at the management of COVID patients in hospitals or the society at large, but rather it is to see how to do our daily practice as an individual of non-COVID patients in these times. So what we will be doing is we'll be looking at the management of a hypothetical example of a case of abdominal pain and discussing about our protection, indications of admission, COVID testing, indications and precautions for surgery, and its outcomes. We shall also discuss a little bit about resource preservation, psychosocial impact, medico-legal issues, some astrology. Coming from India, we can't do without astrology, and some philosophy as well. So we will be having all of that during the course. So ladies and gentlemen, keep tuned, keep watching. Here we come. Let's begin. IAGES has laid down very useful guidelines recently, which you see on the screen, and pretty promptly after the COVID crisis. Now, this is for the surgeons, and I'm sure medical community received similar instructions from their own societies. And what they basically say is that we should operate on life-threatening conditions, postpone procedures that will not impact survival if pushed for 3 months. And the physicians across the country have similar guidelines, and it says limit contact with the patients, use telemedicine wherever applicable, and protect yourselves. So both forums are saying the same message. Do not treat personally if it is not necessary, absolutely. Which brings us to the first question, which I will put to Dr. Pradeep Chaubey, sir. What diseases would you, sir, advise not to treat as absolutely necessary?
Well, I think, good evening, everybody, and thank you, Sarfraz, and thank you, Raman. And I would like to mention here that our fundamental thinking at this particular time of uncertainty about the virus, behavior, treatment, management, prevention, is to be conservative. As far as possible, if we can manage the case conservatively with the help of support medicines and antibiotics, I would like to follow that road and that approach. However, something like, say, acute cholecystitis, etc., can be possibly managed conservatively and do an elective surgery a couple of weeks or couple of months later. But maybe exceptions to this will be, of course, the bleeding situations where there is a acute episode of bleeding and we can control the bleeding, and without control of the bleeding, possibly we will lose the patient. Maybe those will be the absolute indication for operation and surgical intervention. So this is what I would sort of, follow the path of management, more towards conservation and less towards surgical interventions or any type of intervention for that matter.
Okay. So the absolute necessary diseases that need treatment are probably, from the medicine's point of view, heart attacks, stroke, and from gynae point of view, birth deliveries, and then trauma, obstruction, perforations. But I'm going to be talking about a little gray area here, and that is about semi-emergency or gray patients. And there is lack of clarity for many of us on this. Like what happens if of an intractable diarrhea, not responding at home, UTIs, abdominal pain due to gallstones, hernias. What happens to the cancers who are coming out there? So these are being managed through phones and ER. All of us have been returning a lot of patients back and telling them to report after weeks based on what we have been told. Now, there are many stories on the social media, and I'm sure each one of us are hearing this. And patients have become worse because of delay in diagnosis and treatment. Yesterday in our city, we lost a young boy to appendicular abscess, and the cause was possibly there was delay in diagnosis and getting the treatment because all the hospitals are in a state of paranoia. And fever means COVID unless proved otherwise in the city. So that's one thing that's been happening. And here is my take, and I'm going to be playing the devil's advocate here. Things have changed in the last few weeks since we were affected by the virus. We know a little more about the virus. We know a little more about our own protection, like PPEs and face shields. We have got COVID testing now in most cities. There's a progressive accumulation simultaneously of non-COVID cases, like the ones I'm talking about. Paradoxically, now we have more resource than we may have weeks later. Our beds may not be available then. Doctors and nurses may be reporting sick. Is it better to use resource now than later for these gray patients when things are worse? First, I will go to Dr. Raman Goyal, and then I will come to Dr. Neil Smart, because the colorectal surgeon deals with cancers and probably abscesses as well. Dr. Raman Goyal?
Yes. So I think the very fact that word over the elective surgeries is stopped was for the purpose of preserving the resources. And we need to be very, very, very prudent about their usage. And then what happens, the governments and the policymakers are coming out with guidelines which are very ambitious. We just saw in the news today that the BIS, the Bureau of Indian Standards, reduced their requirements for the PPEs. So we need to be very clear about that what PPE should be used in which situation, whether how a policeman or a cop should use what PPEs, and what should a receptionist staff should use. Just using N95 indiscriminately in those situations is as bad, because when the real crux will come, and we will have a very large number of patients, maybe a month or 2 months down the line, hopefully not, each N95 that is misused today will be it will be felt that its lack will be felt. So I think resource preservation is not only for the purpose of finances, but also to save every life of a healthcare worker, and most of them will need it sooner than later. So now we are seeing what's happening in the United Kingdom, that the doctors are already saying that there is a shortage, and they are flying in plane loads from different countries. So I think resource preservation is required now rather than when we are really short of them. So that's my take on this, Sarfaraz.
Dr. Neil Smart, as a colorectal surgeon, you're seeing colorectal cancers and anal abscesses, of different kinds. Some may be gray zone patients, and I'm talking about them. Is it time to address these patients?
Yes, thank you very much for the invitation to join you. In the United Kingdom, emergency surgery has carried on where it's needed to. Like you so eloquently described, there are certain things where we have been able to mitigate. But nevertheless, we're still faced with the burden of patients coming through a system who will have bowel cancer diagnosed. Now, there are those with early stage disease where they could quite reasonably be deferred for a period of time without any adverse impact on their cancer outcome. But there are those who've got time-critical illness, particularly those with slightly more advanced cancers, and those who've had neoadjuvant chemoradiotherapy, or those who are have tumours that have impending obstruction. And they're the ones which cause the great debate, that grey zone, as you so nicely described. And having the opportunity to think about, do we have the resources to operate on them safely? Do we have the resources to be able to carry on operating in the way in which we wanted to or would have done normally, like laparoscopy? We have to consider, and also we have to consider the frailty or comorbidity of the patients and whether they would survive surgery were they to acquire COVID infection in the hospital, which of course remains a risk. And that's generated much heated debate in the United Kingdom. And certainly in my own institution, we are managing to carry on operating to some degree for the patients who've got time-critical cancers, but the capacity is dramatically reduced, and it's a pattern that's repeated around the United Kingdom.
Yeah, difficult times. Let's say hypothetically, there is a 50-year-old diabetic lady with biliary colic who received 3 injections at the ER, in the injections in the ER 3 times before she presents again in the ER for the 4th time. Her vitals are fine and she's otherwise stable. Now, this is a dilemma, and I'll go to Dr. Todd Henniford. And I'd like to ask you provocatively, because I put in the picture of Atlas holding the globe. The Atlas is shrugging, clearly. And in our paranoia of things, do you think we may be under-treating a lot of our patients, non-COVID patients, because of this paranoia of COVID? Or are we justified in doing what we are doing now? Dr. Todd Henniford.
Thank you very much. I very much appreciate the invitation. I think that one thing that we need to set the stage with, as surgeons kicking this off, and I'll ask Neil his opinion on this. When you think about bringing in a patient like this to have a surgery, of course, normally we would operate on her. She'd go home in a day or 2, and she'd be fine. Neil Banger actually presented something I saw 2 days ago from a surgeon from Birmingham. We had 250 patients, 30 days of follow-up, and only 38% of these patients that were suspected COVID positive. So 62% had no symptoms of COVID. All of these patients proved to have COVID. The mortality overall was 25%. And of the people who came in who had an elective operation who then proved to have COVID, 16% of those patients died. So I think, when I start talking to my patients about, well, we don't know if you're an asymptomatic carrier. We don't know. The hottest spots in Italy were the hospitals. Do we subject you to that? My patients then kind of go, I'm okay. I can take a little pain medication. I'll take some antibiotics. I'm good. So I think once you discuss that with the patient, and Anil is brilliant, just a brilliant surgeon, brilliant. But this is the first real data we have with at least 30 days of follow-up on 250 patients who underwent surgery. So set that groundwork first. We are healers. We are doers. We are surgeons who, I don't treat hypertension. I don't treat chronic biliary colic. I bring patients in, I fix them, they go home, they're better. This rubs against the grain for us. And so if I have this patient, I will talk to them about that and about this new study. We're gathering information, much like you said, very quickly. But information like this allows us to make smart decisions about our patients. So one of the things you mentioned too is about testing. Can you test her or this diabetic female, bring her in and then do surgery on her with the testing? But if you do testing, a 30% false negative rate, but then you can also do screening. You ask the patients the questions about fever and about loss of taste and loss of smell and those sorts of things. But you still will have a small percentage of patients who will be COVID positive that you're going to miss. And so for us, do no harm or do as little harm as possible. In this lady, I would try and keep her out of the hospital.
Yeah, I think primum non nocere. I think we will agree with the primum non nocere out here in this. And I think that's a very loud statement that you've made. I'll put it in my summary point that plenty of patients are false negative. And the mortality in the COVID positive patients, even in simple surgeries like this, is going to be very high. And when discussed with the patient, I think most would say, okay, I'll come back. So that's a pretty loud and clear statement from you. Thank you very much. Now, this is the question I'd like to go to Dr. Anuradha Agarwal. Dr. Anuradha, we have, this patient comes to the emergency or goes to a doctor in the clinic. Now, most clinics are closed, but I'm sure so many doctors in the country and outside and abroad are watching this. If they had to see this patient, what is the minimum gear that the patient, the doctor should wear to examine the patient? Dr. Anuradha Agarwal.
Thank you, Dr. Sarfaraz, for inviting me. And I think this is a very pertinent question because in a pandemic, we take every person to be potentially infectious. So in an emergency, which is all the OPDs ought to be closed, only the emergency services should be open. And in our emergency services, we have made available N95 respirator masks to our people who are frontline. Because you never know which patient is going to cough on you, which patient is going to be an asymptomatic carrier. So that is the gear. And of course, if you're going to examine a patient, you have to wear gloves. And of course, the other things which are there where you can auscultate the patient from the back and your other, the precautions which you can take. But the minimum gear which requirement for our emergency people, we have put it as N95 and of course a scrub or a gown and gloves.
Okay, any kind of gloves?
Yes, any kind of gloves.
Okay.
Any kind of gloves, which you, of course, you ought to change with every different other patient.
Okay, all right. Now, so let's say this patient was diagnosed as acute complicated cholecystitis, admission was recommended, and there's something, as Dr. Todd Henniford mentioned in the passing way, which is the clinical screening for COVID. Any patient who's coming to the hospital and going to get admitted is now given a clinical screening, and the reason is that we want to screen people who can be admitted and who are COVID suspected. They may go to the COVID hospital in India, and probably in USA and UK, they go to a COVID ward. Now, here's the thing. These are the questionnaire that we are supposed to ask and get an idea whether this is a COVID suspected case. Cough, fever, breathlessness, recent travel, hotspot, anosmia, loss of taste, and diarrhea. My question to Dr. Abhishek. Abhishek, welcome. How good are these screening questions? What is the sensitivity and specificity? Do we know about them?
Thanks for having me here, Sarfaraz. So these are basically clinical screening questions. No, I mean, just based on these symptoms, first of all, you don't have to have all of them. You could have just one or two of those. Then you have been hearing about the asymptomatic transmitters or carriers. So You can ask those questions, and that will sort of define your pretest probability of somebody having the disease. But the answer is no, you're not going to have a very good sensitivity just with this. In general, if you just see the data, the global data about physical signs and physical examination, it's actually almost just about 50 to 60%. So no, it's not very accurate, but it certainly gives you a heads up about who is much more likely to have it. In the surgical context, it becomes a bigger problem because I mean, you have a much closer exposure and a prolonged exposure when you're operating on patients. So, I mean, usually going with an actual test, a PCR test would be the better thing to do.
Okay. Now, this is the hotspot in India, and I thought many of the people are watching, so it's a good idea to know your hotspots. But it's a very dynamic and fluid state at the moment, and things are changing rapidly. Now, Abhishek, I'll still stick to you. How do you differentiate in this patient? You know, this is an acute cholecystitis, and it's complicated. It's probably gangrene, and the patient is having some amount of tachypnea. How would I distinguish as a clinician a tachypnea between an acute gangrenous cholecystitis and a COVID?
So the first thing I will say, one step back, is if you have a patient who has tachypnea, has abdominal pain, basically acute abdomen presentation, and probably fever, you're probably looking at admitting the patient to start with. In terms of differentiating between the two, you may not be able to differentiate. You will have to just admit the patient, start your IV fluids, antibiotics, send the COVID test immediately so that within 24 hours, you know what the status could be. Again, with the caveat that it's about 70% sensitive in most cases. Then go from there. You will not be able to clinically just differentiate. You will have to test these patients if you're considering treating them.
Okay. So it's not like if you look into the sky, it's not going to be elephants flying, it's going to be crows. But here you can't say that.
You're never going to have a crystal ball in today's times.
Okay. So I know in the USA, all hospitals have a COVID ward and they will admit it there. In India, it is different. We have COVID hospitals and non-COVID hospitals. So Dr. Anuradha, if one suspects COVID infection in this patient with acute complicated cholecystitis, what should be done? We still admit the patient, we send the patient to a COVID hospital, we admit and put them in the ward, and then in an isolation ward, do COVID testing and then transfer based on the result. So how is it in India, Dr. Anuradha?
Well, I can talk about the scenario which we have formed in our hospital. In case this patient reports to the emergency, we of course have the screening checklist. And on that basis, if COVID-19 is suspected on the patient's test is done and the patient is admitted to the isolation ward. We have earmarked few beds which have a different ventilation. Till the time the patient is stabilized, his tests are sent, and then the patient, in case he's found to be COVID-19 positive, he's sent to the COVID hospital. Our hospital is not a COVID hospital, so we cannot treat it. We do not have the infrastructure and the resources to treat it. But the time when the patient is there in the isolation ward, we are treating it as a positive patient, and we are using the whole PPE sets and treating it as a COVID positive patient.
Okay. Scenario 2, there's no suspicion of this COVID and the patient is admitted, and the report and the tests which are done is, and it is touted as something that will be done routinely now for all COVID, is WBC count and chest X-ray. So Dr. Abhishek, how effective is the WBC count and chest X-ray? Does it have a good pickup rate?
Well, a lot of the patients actually have leukopenia. So you might be fooled into just looking at the WBC count alone. This has to be the clinical picture, the chest X-ray. There will be variations in chest X-rays as well. A lot of patients can have a clear-looking chest X-ray, but when you do a CT, you're going to see ground glass changes. In fact, patchy ground glass opacity is actually the classic radiological description of this disease, actually, on the CAT scan. The classic lobar pattern is not as often seen until you hit the late stages of the COVID infection, actually. I mean, when you see a bad X-ray, you're in deep trouble because you're talking about that patient landing on a ventilator. Just like, CT and abdomen, I mean, I totally see the reason for abdomen because you're talking about the surgical issue. Chest, the only reason I would see that as being useful is because you don't want to move this patient time and again to the CAT scan. It's resources as well as exposure to the person. I think there is value in doing that if you're suspecting any possibility, because that means one trip and one-time exposure risk to the personnel. But otherwise, I don't think CT chest is needed specifically for COVID infection itself.
Dr. Neil, if you had a patient of colorectal cancer and you were going to do a CT abdomen, would you add a CT chest for the patient?
Yeah, so for our cancer patients, they often get CT thorax anyway because you're looking for signs of metastatic disease. But many of these patients, if they're going through the scanner as a fairly urgent case anyway, to have a look at what's going on, we'd want the CT thorax to look for any signs of COVID disease. And that's now the guidance that's come out from the British Society of Gastrointestinal Radiology. So if you're scanning the abdomen for pathology anyway, while the patient's in the scanner, you may as well do the chest at the same time, look for any signs of COVID, as well as having swabbed them, because we know that there's a 30% false negative rate in swab. So particularly if you're going to operate on the patient, it will influence what you may or may not do.
Abhishek, we live in a country rampant with tuberculosis and chest, CT with tuberculosis. Is it going to make a difference to interpretation?
Like TB versus COVID-19 infection, you mean? Absolutely.
Yeah.
Yes, that's a very different looking thing. TBs are usually upper lobe predominant, often cavitary. Not the case with COVID infection. COVID infections are usually patchy, slightly peripheral, very attached to semi-solid looking. They're not lobar consolidations, like I said earlier, until the late stages of the disease. So yeah, I mean, you will be able to, there's a radiographic pattern that has been published now. If I remember correctly, either JAMA or Lancet, one of the two papers, they have a full radiographic presentation paper on it.
Okay. Now, let's say this hypothetical case has an empyema, is being treated conservatively, but it's not responding, and there is a decision to operate on this patient. And COVID testing is something that is being talked about routinely for all patients prior to surgery. But we know in India, some hospitals have made it a routine, like Dr. Pradeep Chaube's Max Hospital has made it a routine, whereas some hospitals are not doing it routinely. So I'll go to Dr. Anuradha. What is the protocol? Should we do it routinely, even if it is not being done now? What do you think, Dr. Anuradha?
I think first, the most important thing is to stay totally conservative. In case there is a surgery, as you said, which is you have to do, I feel that we ought to be testing the patient for COVID-19. And as far as the test which should be used for this is, of course, RT-PCR now, because antibody testing is not going to solve any of your problems. They are basically, the antibody tests are only to detect maybe asymptomatic cases, maybe reveal evidence of a previous infection, or maybe verify that the vaccines are working, during clinical trials, and also maybe for contact tracing, weeks longer than after they have had an infection. So I really do not know what an antibody test pre-op is going to help you to do in your surgery.
So just explain it to us a little simpler. We are getting something called a COVID test, and I think we are talking about antigen test, right?
No, the COVID test which we are doing right now, the test which we are doing right now is RT-PCR. It is a real-time reverse transcriptase PCR, because coronavirus is an RNA virus, and we do it as a molecular test. Yeah, and it's done in a biological safety cabinet too.
And you think the antibody tests which are coming in the horizon, what is it you're saying? You're saying it's not going to be very useful. It's going to tell us about the immunity, but it's not going to be a great test for picking up acute infections?
Yeah, the NIV Pune has already, I think, seen around 16 kits, antibody kits. They have verified it and they have found it useful. But again, the whole purpose of having an antibody test is not for acute infection. They cannot diagnose an acute infection per se.
So what just going to give us? Only immunity?
Well, immunity also, because we do not know what level immunity is protective. Like for hepatitis, antibodies to hepatitis B, we know, okay, above a certain level, it is a protective antibody level. But for SARS-CoV-2, we do not know. We do not know. So antibody tests are just going to tell you an evidence of exposure some time ago, and whether it's useful for contact tracing in hotspots. That is an important thing in it. But for diagnostic thing, I don't think it has much value.
Right. So, Dr. Anuradha, if this patient turned COVID positive on testing, unsuspected patient who was admitted to the hospital, was being planned for a surgery, had a conservative treatment initially, and the report showed COVID positive. Now what happens?
You mean the surgery was done without taking the all precautions?
No,
or
the
you're going to
surgery has
operate
not
now?
been done. The surgery has
Okay,
not been done.
okay. Sure. No, I think
Would
this is a
you
very,
transfer
very,
the patient?
yeah. So a low, no, well, you can do in case the surgery is an emergency saving procedure, you will probably have to do the surgery in the hospital. For that, you really need to earmark one OT or two OTs for doing that particular surgery. You need to have a team. You need to keep only minimum number of people. The communication between everybody needs to be very clear. Your transport of the patient should be from the shortest route possible. The operation room should be an airborne precaution room because you're going to intubate the patient. So it has to have an HEPA filter. You need to make sure that all your personnel are wearing the proper PPE equipment. And very important thing is that when you're wearing a N95 respirator mask and you're wearing a screen, the audibility is very low. So you need to be very loud in case you're going to communicate to your assistants and your sisters while operating. And of course, after that, they recommend that the recovery of the patient ought to be in the same room so that you're not taking him to the recovery room. You're going to put the recovery of the patient in the airborne isolation OT itself. And of course, there are so many things which the anesthetist probably will know better. Yeah.
Right. Now,
and then decontamination after that. That is so very important. Either you do it as the last case, and then the decontamination of the OT is so extremely important. Very, very important.
I'll go to Dr. Chaube. So in these patients, when we are going to operate on them, we need to take a consent or no, because we are aware that if a patient in a hospital is in a hotspot, and if they turn positive later on, would they blame the hospital and the doctor? So Dr. Chaube, what about consent of these patients? Dr. Chaube? Hello. Dr. Raman Goyal?
Yes, Sarfraz.
Oh, is Dr. Chaube not available?
I think so. I don't see him here. Maybe this connection is lost.
Okay, maybe. Then I think, can you take this question?
So, Sarfraz, this is a gray zone. Obviously, everybody knows that they are going through this, but a patient who is asymptomatic does not believe that they have a COVID disease. So if you operate them and post-operatively they develop a COVID disease, they can obviously blame the hospital or the staff for giving them the disease besides the cure of their surgical problem. So I think at least in Indian situation, we need to have a consent signed that they are aware that there is a pandemic and they may be an asymptomatic disease, asymptomatic carrier themselves. And it may be, even if you do a test, it may be false negative. So I think doing a consent is obviously desirable. And most of the organizations have now drafted a consent which is available on their websites. So I think it's a valid defense for the hospital and for the team. Already there are some issues happening, if not in the courts, but in the media. People are taking it up as a something that came from the hospital.
Right. So this is the concern that we picked up from one of our hospitals in India, where they have mentioned that the patient and the family are not going to charge the hospital or the treating doctors if the patient turns COVID positive after the treatment. So now coming to the intraoperative strategy, it is being recommended that intraoperatively, to reduce the probability of viral transmission, the number of OT staff should be minimal, staff should be tested, and PPE, face shields should be worn. Use of cautery and laparoscopy should be minimized or avoided altogether. So I will touch upon these few things. I will talk about PPE with Abhishek, and I will talk to Dr. Todd Hanniford about the laparoscopy part and the use of energy source. So let me just go to Dr. Abhishek and ask him, Abhishek, the problem that we are seeing in India, there was a huge confusion about the specification of a PPE. And I went through it myself, and it should be a sandwich of a spun-bound, melt-blown, spun-bound, non-woven plastic with greater than 40 grams per square meter, and should cover from head to toe. But there's an absence of clarity, and there were various small-size manufacturing units which mushroomed to produce PPE. Many are good, but some are not conforming to the standards. And some have even confused it with the HIV kit. Now, I want to ask you a simple question. How is it different from an HIV kit?
So I think the most basic or the biggest difference that will make a life or death difference from an HIV kit is the N95 respirator. HIV kits at best will have your regular surgical masks that are obviously not protective against the virus, or I should say very minimally protective against the virus. I shouldn't say not at all protective. N95 is desirable, absolutely. I mean, other than the N95, if you have a face shield, if you have a head, a hat, all the rest of the stuff, you can use the HIV kit if somebody's supplementing with an N95 mask. Now that is for procedures generating aerosols. If you don't have a procedure generating aerosols, you could, under situations where you don't have N95 masks, go with your regular surgical mask as well. I mean, I don't think in a non-aerosol generating procedure you need an N95.
Okay, thank you, Doctor. And these are the face shields that is available. I want you, Dr. Abhishek, to tell us about these face shields. There's so many, and a friend of mine sent it across, and I said, you know what? I'm more confused now. Which one is it that you're going to prefer, and why?
Yeah, so it's interesting. I would like to have a Boeing 747 for myself, but I can't afford it. That's one thing. So is a P100, I want to be very objectively clear about this, is a P100 better than N95 in terms of filtration capacity? The answer is yes. Do you actually need that? I don't think so. Can you actually afford it at a mass level? I don't think so even more. Option A seems to be the most reasonable, cost effective, also fairly protective. You have an N95, you have a face shield, and as long as you make sure that you have the gown and the head hat, I think we're okay.
All right, great. Now, there has been a lot of debate about the usage of laparoscopy in COVID crisis. It is argued that pneumoperitoneum will lead to the creation of aerosol droplets, and leak gases have a high chance of transmitting the virus. And many guidelines have recommended that laparoscopy should be avoided altogether. Dr. Todd Hanniford has been in the front on the subject of utilization of laparoscopy in the COVID times. This is his algorithm that was well and popularly received from all around the world. So Dr. Todd Hanniford, should we avoid laparoscopy in general? And where can we use laparoscopy in your opinion?
I think it's a pretty loaded question. If you look at this panel that you've assembled, all of us have been career-long proponents of minimally invasive surgery. I mean, we've taught it, pushed it, pressed it, published on it. And now to take a step back and say, we have to think about laparoscopy. There are a few unknowns here. One, is there actually viral particles in pneumoperitoneum? And the answer is we really don't know. We know it's in the stool. We know it can be in blood. There's up to about 20%, between 0 and 20% of the time it's involved in the blood in patients who are COVID positive. The other consideration is if it is in pneumoperitoneum, the spray of pneumoperitoneum, the concentration of pneumoperitoneum, the evacuation of pneumoperitoneum, I mean, you get a high velocity push outside the abdomen. And so I think that there's real controversy in doing the laparoscopy. If you look at this algorithm, if you go down, one of the things we mentioned earlier is about a CAT scan. Is that if you go down and on the right side of the screen, if the patient can be tested, the answer is no. Can you get a CAT scan of the chest? And there's actually 2 studies that demonstrate the CAT scan of the chest actually is more accurate than nasal swabs. And so that is part of our algorithm. And what we want to do, if we have someone who's COVID positive, we're not doing laparoscopy in them. So we have one essential resource in the hospital that we can't replace, and that's the staff. I mean, there are 2 things that are super important there. One is that if you're going to show your staff that you care about them. You're going to show that the staff that they're super important. And I think that, the hearts and minds of the people who walk into the hospital every single day and face this, and it's scary.
Yeah.
We show them that we care about them, and we're going to make decisions about it. The second thing is that, we don't know. We can, if you look at pneumoperitoneum and you look at hepatitis B, you look at coronavirus, you look at HIV, we know that those viral particles can be in that. And the argument is, well, those people, you haven't had documentation of catching that virus through pneumoperitoneum. But we're talking about a virus now that is so dramatically more infective than any of those others.
Right.
And just because it's unknown doesn't mean you should do laparoscopy. An unknown does not prove anything. And what you have to do in this is gear back, think about what only operate on the patients that you really need to operate on. And I will tell you too that the consideration of like doing an appendectomy in a patient who's suspected COVID positive, fever, perhaps a cough, perhaps played on chest X-ray, they come in sick. I can do an open appendectomy through a small incision, still send them, the majority of those patients home even tomorrow, versus doing a laparoscopy. The same thing with a cholecystectomy. I can small incision, local injection, local anesthesia at the end of the operation. They still go home very quickly. You don't want to expose these patients by doing a big laparotomy to the hospital system for a long time, and I totally get that. But you've got to protect your faculty, and what what I'm going to be is protect my staff.
Thank you very much. Very well said, Dr. Todd. It looks like it's going to be difficult going back to laparoscopy after the COVID crisis. But tell me about the energy source usage. I've read articles saying that the cautery produces the worst particles and the ultrasound shears producing the effective particles. The size is bigger and therefore it cannot penetrate. But the cautery particles are going to be smaller, they can penetrate. So how anecdotal or how evidence-based is that statement?
There is data to support that, and so even in open operations, if you're going to do a laparotomy, open appendectomy, open cholecystectomy, perforated diverticulitis, and you're going to do open surgery, use the minimal amount of energy source you can. And if you're going to use cautery, use it at the lowest level possible. You're going to suction your smoke, and if you have the scavenger pencils, cautery pencils with the suction on the tip, I would use those 100%. And or have someone with the sucker tip over the field to suction any smoke that might be missed.
Okay.
You're correct about smoke from cautery, smaller particles don't travel as far. Harmonic scalpel and other energy vessel sealing type devices, bigger particles, they may actually travel further in the operative field, and both would be considered possibly infective or dangerous.
Now, this is a hypothetical question, but it is important, and I will take this as Dr. Anuradha. Let's say this hypothetical patient underwent a surgery, was sent home. Within a day, the patient had fever. Patient's COVID testing returns as positive. Dr. Anuradha, what do you do about the doctors and the staff and at that OT room and the OT campus, or even that hospital? So I'm going to make a very loud statement. Are you going to quarantine all the doctors and the people who are involved in the treatment? A, are you going to shut that OT room? Are you going to shut the OT campus? Are you going to shut that hospital? Dr. Anuradha?
Hello?
Yeah, Dr. Anuradha, I can hear you now.
Yes.
Did you get that question?
Yes, I did.
Okay.
We first and foremost, we definitely are going to quarantine all the doctors and the staff which were involved in the treatment of the patient. We're going to do an elaborate contact tracing, which is very, very important. And of course, the decontamination of the OT and the transport which the patient took. That is why very important to do the whole contact tracing. And then the quarantine, we'll have to follow up the guys for in case they develop symptoms, and go according to the guidelines and test them as well.
And do you shut the OT campus?
I don't think we need to shut the OT campus. I mean, we have a very good housekeeping and decontamination happening. It's a highly infectious virus. We need to keep that in mind. It is really, really infectious. So a very thorough cleaning of the place is required. And maybe we can close it and do a very good thorough cleaning up of the OT campus and keep the OTs off for some time.
Yeah, you know why I was smiling, and I think Dr. Raman Goel was also smiling, is because this sort of thing happened in India. You know, one OT returned with a COVID positive, and the entire hospital was shut down. I think there was some lack of understanding about the situation, and I think this is the time when awareness programs like this go a long way in dispelling the myths and misconceptions. Dr. Chaube, are you back?
Yes, I'm
Sir,
back.
okay. So in this patient, sir, where the patient turns COVID positive, again, same thing. What happens in the court? Are you safeguarded that we did our best and, well, it turned positive? If you've taken a consent, does it protect you? So what happens in the court, sir?
Well, I think it's very difficult to say at the moment what happens to the court, because I think everybody knows about the potential of infection and possibility of infection, and also the asymptomatic carriers. So I think there will be a lot of ambiguity about the legal issues, and I would like to mention that we are having at least one case who has filed the thing that he got the COVID infection from the hospital. So that raises another very interesting question, that all the personnel who are taking care of any patient, COVID or non-COVID patients, should they all be treated, investigated, or should be proved, or whether they are non-COVID doctors and the paramedical staff? So that is a big question which needs to be answered. And at our institution, we have taken a decision that we have about 24,000 employees, and over a period of time, the persons who are coming in active, sort of taking active practices, would be investigated, and their COVID status will be known to the organization before we put them on the job.
Okay, sir. Now I'm going to be asking a very disturbing question to Dr. Neil Smart. What happens if a doctor becomes COVID positive and has a fatality? What does the hospital and government do for the family? I ask you because I think in UK this happened, and I would like your perspective on it.
Yes, certainly. It has indeed happened in the United Kingdom, sadly. There have been a number of fatalities of frontline healthcare workers, including surgeons, particularly ENT surgeons, and ophthalmologists are known to be particularly high risk because of the aerosol generating procedures they do and the proximity with which they get to the respiratory tract of the patients. Within the United Kingdom, if they are on active service and they enter the pension scheme, they do get a death in service payment. That is not standard across all NHS employees, though. But certainly in the UK, that would happen. But of course, there isn't much more that happens other than that. If the pension's set up appropriately, the spouse will get half of the pension afterwards, depending on the age of the doctor when they die. It's certainly a very sad time, and we've seen deaths already. I suspect before this pandemic is done, we'll see more. It will come to the fore as an issue.
Yeah, so I come to the part where I'm going to talk about a little psychosocial aspect.
Sarfraz,
Yes,
may
sir.
I interrupt here? I think,
Please.
because in Delhi, I think it is very encouraging that the Chief Minister of Delhi has promised 10 million compensation for the healthcare workers who unfortunately might lose life in treating the COVID patients. And also, I would like to highlight a couple of states in India. For example, Rajasthan, I think, the government, they are paying double salary during this period. And another place, I don't remember which, they're paying 3 times the salary to the persons who are directly engaged in and actively looking after. So that's a part of it. And they have added medical insurance of 50 lakhs. That's what, 500,000.
That's great. I think these are great information. Really, it's. I think those who are watching, I'm sure it's a very difficult time for anybody who has a problem like this. But there's some incentive, some silver lining, I would say. So we are living in a state of fear, uncertainty, lack of clarity. People do not know how long this is going to last. Doctors do not know how long we are supposed to lie low and work like this. When do we resume normal work without fear? The government is also struggling to get its act together, and it's not easy when something so huge has hit us. And many of us are experiencing this mixed emotion of fear, paranoia, anxiety, depression, and loss of control, especially the last one, the loss of control. And I can speak for myself. My family, my mother and my wife, she's a doctor, but she hates it when I step out of my house and go to the hospital. And she keeps saying, my mother keeps saying, do you really have to go? And I will confess for myself, I had to operate on a patient recently with the PPE gear on, and it was difficult. I was perspiring. I was shouting, as Dr. Anuradha said. And one thing that was playing on my mind was that a fellow colleague of mine is on a ventilator with an acute kidney injury, with a COVID infection. He's an orthopedician who contracted it about a week back. And that scares you. Those kind of things scare you. It plays on your mind. And I think we are, when I say I'm now referring to the entire doctor community around the world. We are struggling with our emotions. Many of us are struggling with their emotions. We do not know how to deal with it. And I would like now to go to Dr. Chaubey. So you've always been a philosopher and you've been close to His Holiness Dalai Lama. What would you like to tell us in this hour of crisis where there are so much of mixed emotion? It's nothing medical, I'm asking you. It's something, any words of wisdom at this time?
Well, I think we all know that we all are human beings, and our emotions, our feelings and our fears and our anxiety is all natural. So by profession, we are doctors. That's the only difference which we see, and we have no other choice but to look after our patients who come to us for that. So I would say that we must understand that we all are human beings and we will behave exactly like any other person, apart from the fact that we are doctors and we have to take care of our patients. And here I would like to bring some points which have been discussed in the previous with the previous speakers, that at this time I would like not to pay any attention to the cost involved, etc., anything which is for protecting our medical colleagues and paramedical staff and the staff who's taking care of the COVID patients. I would put whatever is necessary to prevent them, because it is not that their life is more important, but I think it's very important for them to be active and taking care of the patients, COVID or non-COVID patients, rather than sort of losing life by saving a couple of thousand rupees or couple of $100 or $1,000 in having a protective gear which is less than the best.
Right. So the other blow we'll need to grapple with in the near future is the economic crisis. And I will limit our discussion for the doctors only. Many salaried doctors will probably be told to become fee-for-service doctors. I know that for sure in India. It might happen. And there will be higher risk in working. The wages may still go down. I just want to know from our friends from USA and UK, Dr. Todd and Dr. Neil, we heard Dr. Chaubey saying that the government here is incentivizing the work, the wages for the doctors. What's happening in UK, Dr. Neil, and then we'll go to Dr. Todd for USA.
So at the moment, my salary and salaries of doctors generally will not be affected. Although what happens going forward once we come out of this, who knows? We're more likely to get redeployed though, because we are salaried. And of course, as the government is our sole employers, we have to do what they tell us by and large. So if we get redeployed to areas other than our area of specialism, it does happen, and surgeons have been redeployed either to medicine, to intensive care, frontline in accident and emergency. So the government will make best use of the resources that it's got for healthcare, and that might well continue for some time after the worst of the crisis has passed and as we come out and start the recovery plan.
Dr. Todd? I can't hear Dr. Todd.
I'm a hospital employee, and we have private practice surgeons as well. I am super proud of my hospital at this point. They are continuing to pay us, and that you don't get paid anything extra, and I would never ask for it. But of course, the consideration of working in this day and time, they are protecting us. I have a number of private practice physicians, really good friends of mine from New York, local surgeons who are there. They are taking the hit, and they're fully supporting their staff. And so I'm super proud of those physicians who are friends of mine who know that their staff sometimes will live paycheck to paycheck. I think one of the things that Dr. Chowdhury mentioned, which is I think is super important, is many of the physicians and many of the healthcare workers are going to end up with some PTSD after this. And perhaps one of the way to remunerate those folks is, once this is over, is to address that and have the facilities and the personnel available to help take care of that. The psychological impact of this. If you don't have psychological impact of this when you go into the hospital, you're not paying attention. In our studies in the United States, 11 to 20% of all tests that are positive are in healthcare workers. And we have to acknowledge that. We have to take care of that. And I will tell you, it's in every portion of the population, or of every generation, one segment of society steps up and takes care of the population. And it's our turn. It's been military people in the past, first responders for us for 9/11, and now it's our turn. But there is a cost, and there will be a lasting cost in this.
Yeah. So I come to another very disturbing picture here, and I would apologize for putting it there. So 9/11 attack on Twin Towers changed the way we travel forever. The COVID crisis has the potential to change the way we do clinical practice. Will we see, and I'm going to be asking this question, and I will have a quick response from each one of you. Will we see all patients as potential COVID in future? Will we routinely test for COVID as part of hospital admission, just like we test for hepatitis B, C, and HIV? Will we take universal precautions like in HIV? Will we start seeing our patients more on telemedicine? Even in the OPD, will it be feet apart? Will we restrict entry of visitors in the hospital? Will we add a legal angle for someone who contracts COVID in a hospital while undergoing treatment? In short, how is the world, especially of doctors, going to change? I wrote the bad points, but any good that comes out of it, I would like your comments. So I'll quickly go to Dr. Todd Hanniford first. Then I'll go to Dr. Anuradha, and then I'll go to Dr. Chaubey.
I think that you hope there is going to be a lot of good that comes out of this, and that the resurgence will be strong, and we will learn a lot. It's like compared to like with NASA and all the things that came out of NASA that made us better just by going to the food. It'll be simple things like just like hand washing. The public, for healthcare providers, but also the public. But for us as minimally invasive surgeons managing pneumoperitoneum, I think we're going to be managing pneumoperitoneum differently from now on infinitum. There have been some things like, we've developed virtual hospitals. We have patients now that physicians are rounding on them at, just like this, rounding them in their home and keeping them out of the system. They don't go see their doctors. They're not infecting other people. I think that perhaps one of the really super important things is that we're like, when you look at this attack, I think we should be better prepared to prevent or to step up to the next viral wave that comes. And it will be like developing vaccines, and also government approval. Testing and government approval will change and will change for the better. And the last thing I mentioned a moment ago is like, this attack and this attack, the first building came down, 350 firefighters and almost 40 policemen died immediately when that tower came down. And this drew attention to the first responders. And I think what's going to happen here is that the healthcare providers now are going to be, you're looking like in New York, and it's happened in England, it's happened in Italy. People would come out at 7 p.m. and clap for their healthcare providers. It's like, it's so touching. And I think I think we're going to be, our importance is going to increase.
Thank you very much. Dr. Anuradha, I think that was brilliant, Dr. Todd. Dr. Anuradha, what do you think is going to happen?
I think this COVID-19...
Yeah. Please carry on.
I think certain things are going to change for the better, definitely. Because as an infection control preventionist, I feel that, as Dr. Todd also mentioned, your hand washing, I see the people even on the road washing their hands. So I think as a public health attitude towards hand hygiene, that is going to increase your respiratory cuff etiquette. Because, in India, how people spit, so I think that is a very good awareness which has been created for the people. And one very important point, which I feel very proud of, is that India is getting self-sufficient. It is gaining the confidence that it can isolate the virus. It can work towards the virus, because India was one of the very few countries where we isolated the full genome. And IV Pune is doing a brilliant job of it. It is giving a lot of confidence to our science people who are working at it. And also the attitude of the government towards the healthcare workers, the kind of work which they do, the help from the government has, I think, improved a lot. And I also feel that, the interpersonal relationship between the healthcare workers has increased a lot. We've been so thankful for our staff, which does the decontamination and cleaning of our rooms. And as Dr. Todd pointed out, that when they are clapping for them, we did clapping for all our Group D, the housekeeping staff. And their morale is high, and they are saying, doctors, we are with you in this. So a lot of good things have happened with it, and I'm sure, but it's going to go off. I don't think it's going to be will be something like H1N1 with higher infectiousness, but with lesser mortality. And we might see a wave of it again coming in the autumn towards the October, like your other flu viruses. Hoping that it doesn't, but then by the time we'll be more prepared. And thankfully, I think we should be coming with a vaccine, because I think recently Oxford said they would be able to come with a vaccine by September or something like that. I read up yesterday. So we're going to be good.
So with that, I think I will like for all my visionary panelists here, not only doctors, I don't see you as doctors anymore. I see you as visionaries. I see you as astrologers. I see you as predictors. Tell us with your wisdom, what kind of time frame are we looking at for normalcy, for sanity to prevail? So, Dr. Abhishek?
Well, normalcy could be defined in many ways. We're talking about medical practice normalcy, daily life normalcy. Well, for daily life normalcy, I will tell you one thing. Usual pandemic cycle is 18 to 24 months. Now we have 100 years of timeline between the last and this one, and we have made a lot of progress. So at best, I would say at least 6 to 12 months in terms of getting back to your at least quasi-normal clinical practice, probably 3 to 6 months.
Okay, Dr. Anuradha?
I think we're definitely going to have a research of the thing. As far as Dr. Abhishek said, you need to define what normalcy means. It is definitely going to change our thinking in
no, but how many months? Diseases. How many months? He said 18 to 24 months. What about
yes,
you?
I think so. To recover from a pandemic, big pandemic, it is studies have been done which show that at least takes 2 years to come back to normalcy.
Okay, Dr. Neil Smart. What's your hunch?
Probably 12 to 18 months before we get back to what turns out to be a new but different normal.
Okay. Yeah. Dr. Todd?
Yeah, it's when we can get a vaccine. When you have an effective vaccine, then we'll be able to get back to normal. And how long that will take, that's it's always going to be longer than we think. unfortunately.
Okay. Dr. Pradeep Chaubey, sir?
Yeah, I think so. I quite agree that it is going to take, if we say 100 years back, it took us 2 years, maybe half of that this time.
Yeah.
And especially if we are looking for the vaccination, possibly, and some of the antiviral so-called drugs, which might come.
Right.
So it may have a little shorter sort of thing. And also, I think little differently on this way because of it's highly infectious. So the chances are that the community sort of prevention and immunity will also develop sooner than as compared to the other viruses.
Okay.
So
Dr.
that
Raman
is the
Goyal?
point which I feel.
Okay, sir. Dr. Raman Goyal?
So, Sarfaraz, my take is ultimately it's an infection.
Yeah.
So what happens? I mean, you learned from the history that it took 2 years, but this time we have all the researchers, the pharma industry working overnight, round the clock. What happens if a drug comes 3 months down the line? So let's be hopeful. Obviously, the timeline is 12 to 18 months, but if something comes earlier than that, it can just go away very fast.
Right. So, with that, I think I'll just put in this slide, and I think if you just go through this duck cartoon, you will like it. This is my favorite cartoon on a daily basis. I have it pinned up on my. As soon as I wake up, that's the first thing I see, and it makes me better. What it says is that there's a discussion between the duck and the man. That the man says in the COVID times, the world is changing, and the duck says it's always changing. The man says our lives are in danger. We are in lockdown. The duck says life is always dangerous. We were never free. The man says, many of us could die. The duck says, we all get our turn. Nobody knows what's going to happen. And the duck retorts, nobody ever knows. This makes life interesting. And the man says, we don't believe what to believe anymore. And the duck says, keep an open mind. This also makes life interesting. And finally, the man says, we are living in strange times. And the duck says, when were we not living in strange times? So, and I added the last one, where I feel that man always believed that we have lost control of our lives and our world. And I think the duck would say, when were we ever in control? And with that, I think I will finish off this webinar with a great thanks to my panelists. It's not over yet. There are plenty of questions which we have to answer. But as far as we talking concerned, well, that's the end of it. I'll put in the summary points as to what you said. My colleague, Dr. Pallavi Priya, was kind enough to do that for us so that we don't have to wait. And while we do that, can we have the questions, Pallavi?
Yeah, we can. Should we do the questions before we do summary points?
Yes, let's do the questions first then.
All right. So I have tried to organize the questions in some form of sequence here. I don't have the name of all the people who have asked questions, so I'll just put the questions forward. The first
Right.
question, I think, Dr. Abhishek, you can answer. Someone is asking, are we going to overdiagnose clinically because these symptoms are very common?
Are we going to overdiagnose? Can you say that again, Pallavi?
Are we going to overdiagnose clinically because these symptoms are so common?
Okay, Dr. Abhishek, will you take that?
You're not going to overdiagnose. You're going to screen, and there is no amount of screening that can be called over-screening. You're protecting yourself as much as you're doing your job to the patient. Your suspicion, once you look at the clinical picture, then you test. And yet, if your suspicion is higher, because the test accuracy is only about 70% right now, or 65 to 70 probably, you're retesting. So your clinical suspicion should always take precedence. If you suspect, do not just put your guard down and go in front of the patient without proper care. You will not be overdiagnosed, you'll just be screening.
Thank you. The next question, Dr. Henniford, you can take this question. There's a person who's asking, what is the evidence that laparoscopic procedures are dangerous? And yes, it came with 2 question marks.
I totally get it. I mean, we don't have data that say that laparoscopic procedures are dangerous, and but the problem is we don't have any data that say they're safe either. And so we do know about plume, we do know about cautery plume, we do know it's in blood, we do know it's in feces, we do as GI surgeons. And so what we have to do, for me, what I'm going to do is be as safe as possible. I don't want to, I do not want to put my patient at risk, but I also have to preserve the safety of my team. I think that, if I may, that last question about like overdiagnosing, one of the issues we have in the United States, the CDC says, if you look at our death rate, the CDC says you don't have to have someone be tested positive to say they died of COVID. It's only if it's suspected COVID. So if you look at our death rate, we don't really know what our actual death rate is. I wanted to fall back to that because just like the interpretation of all this data that's coming out. But back to laparoscopy, we don't know. So just take the safest route.
So can you give some guidelines or some tips if someone is using laparoscopy for a patient of theirs? How can they make it safer?
Yeah, you want to use the cautery at the lowest setting. Limit your of course you don't want to have bleeding, but limit your adjunctive vessel sealing devices as much as you can. You do not want to decompress the abdomen into the OR environment. You want to, if you're going to do a laparoscopy, you want to suction out all the pneumoperitoneum you possibly can before you make an extraction incision or remove a specimen or something of that sort. The other thing is if you have a filtration system such as PneumoClear, what actually filtrates it circulates the intra-abdominal environment, and before it expels it through the back of the insufflator, it actually goes through a filter that will filter down to 0.05 microns. And so you will catch the virus, 99.9% of the virus, before it might be expelled in the operating room.
Thank you, Dr. Hanniford. I think Pradeep Chaube, sir, you can take the next question. Dr. Mahesh Kunjanwala is asking, a patient comes with fever and acute cholecystitis. What should be the routine test? Should it be COVID antibody or COVID antigen?
No, I think the patient needs to be having both in a way. I think, first of all, we have to treat the patient with antibiotics, etc. And in the given circumstances, may not be admitted in the hospital. But if it is, if the person is admitted in the hospital, we have to know the COVID status of such patient before admitting, because we have to see which side of the ward the person goes in. So I would like to treat this patient not as an indoor patient, but maybe injectable antibiotics can also be and maybe given at home. So it's sort of that situation. And COVID status has to be clear to the treating doctor, because anybody coming in contact with that person, medical personnel or paramedical personnel for the taking care of that person, the COVID status should be very clearly known to the treating team.
The next question is on the similar lines, a patient that comes with empyema gallbladder. There is no clinical history that suggests patient is COVID positive, RT-PCR is negative. What are the treatment options for this patient?
Well, again, we will make it conservative, and if at all it is necessary, maybe do a surgical intervention, radiological intervention, and maybe drain the gallbladder. Under local anesthesia, we can do that, go through the liver and drain the gallbladder, the infection, and wait for things to settle down and then go ahead and do the surgery afterwards.
Okay, and the next question, I think Dr. Abhishek, you can take this question. This person is asking, PCR takes about 24 hours. If they have a patient of perforated viscus, they cannot wait. Would an HRCT chest be enough in this case? How would you approach this patient?
So first thing, you don't need an HRCT. HR is the high resolution part. Most of the CAT scans done today's times are with 1 to 1.5 millimeter. cuts. So a regular non-contrast CT test should be just sufficient for a COVID infection. That's the first part. Do we actually need that or not? It all depends on the clinical picture. If you have an unstable patient, I mean, perforated viscous oftentimes ends up with a hypotensive patient and severe shock and all that stuff. You don't want just that patient to be going through all the, transportation and other things. If you suspect a COVID, just don appropriately with PPEs. Do you want to send a patient for CAT scan? Again, if your patient can tolerate it and that's the only way you're going to find out, go ahead.
Okay, thank you. And another question. What should be done if a patient tests negative for COVID, but after 1 week in the post-operative period, they develop fever and test positive? Dr. Anuradha Agrawal.
Yeah, I think this is probably a case of the patient being operated during the asymptomatic phase. And so it is extremely important. I think I totally advocate that in case you are operating on a patient, the COVID status of the patient should be known, should be found out. And of course, you will have to isolate the patient and wear your PPE and take care of the patient in the isolation ward. Totally.
And ma'am, do we do some sort of a contact tracing for healthcare personnel?
Yes, of course. Yes, of course. Yes, of course. That and all will totally follow because you will have to do a total contact tracing, quarantine the people who were there, and among the people who were there in the OT, whether they had donned their proper PPE or not. The full contact tracing, the full quarantine thing has to be worked out for the patient.
Thank you, ma'am. And this question again is for you. What happens if the surgeon tests positive in the post-operative period in a COVID negative patient?
You mean to say the patient was operated by the doctor during he was positive?
Yeah.
When his status was positive?
I think that's what it wants to say. Yeah.
Oh. I hope the surgeon knew about his thing that he took proper PPE, but the best prudent thing would be to not operate in case you are testing positive, no surgeon who tests positive ought to be.
Dr. Anuradha is already operated. I think the patient's COVID status has to be tested now to see if he's going to turn positive because of the exposure.
Yes, of course. The exposure in the patient has to be tested, and so also his other people, and of course the contact tracing and the quarantine has to be done accordingly.
Dr. Abhishek?
Well, if the question implies the legal angle of it, I don't think the surgeon is going to have a liability because he himself did not know. If you're an asymptomatic individual carrying the infection, I don't think anybody can blame you because you had no symptoms. You did not know. You're an essential personnel. You have to come to work. It's not like you're, ordered to sit at home in isolation. So if the surgeon did not know he was positive, he had no symptoms, then, he had no intentions of harming.
Yeah, and
there is
from the
no medical legal implications, but of course the contact tracing and you have to test your patients on whom you have operated during that time.
Absolutely.
Do geriatric age group patients need special care? Again, I'll send this question to you, Dr. Abhishek. You are a geriatric physician as well.
Yes.
You can see what are the points to be considered while counseling these patients.
Absolutely. The first thing you have to know is their pre-existing disease profile. They need very special care, and I will say this over and over, and Dr. Agrawal will agree, do not touch a geriatric age patient unless you're really going to make a life-saving intervention. Don't bring them out of their home. Do not try to test them unnecessarily. Try to counsel them. I struggle with this with my own father all the time. He has small problems. He wants to go to the doctor right now, and I keep telling him absolutely not unless there is something that's killing him. Special care, well, the first thing I think, and again, this is going to sound very morbid for a surgeon, make sure that you know what their advanced directive wishes are before you touch them. If the advanced directive says do not go crazy, because there's one more thing, and again, I'm going to say this with a little bit of hesitation. In India, the idea of going on a ventilator is very different from the idea of going on a ventilator in the Western world. Half the times people assume the ventilator is actually not making any difference to their life, or maybe actually even a means of making money. I'm going to just be very blunt and say that. That is often a consideration. do ask them, if you need a prolonged ventilation, if you need a chest compression and all of those things, what are you going to do? If they are answering, I don't want any aggressive intervention, then what you are planning for is already aggressive. Don't do it. Save yourself, save the patient. If they say they're willing to take all the risks, test them, protect yourself with all the PPEs, and then go ahead because they're taking all the risks.
I think we are clear enough here. Do not bring the patient out of their house unless you're going to save their lives. And Dr. Pradeep Chaubey, sir, this question probably for you. When would you consider it safe to resume normal clinical or surgical work? Where do we stand on this?
Well, I think we have to watch the trend for another 2 to 3 weeks and see how the things are. Either it is the
I think we have
Lost his signal, I think. Yeah.
Dr. Hannifin,
is flattening, or if
we can't hear him, right?
yeah, we can't hear, sir. Can someone call him? In the meantime, Dr. Hannifin, can you take this question, please?
It's safe to resume, clinical work. A surgeon would be, be put in a penalty box, or you'd be at home for 14 days. You'd have to be totally asymptomatic, and then you'd be considered to come back to work.
And in terms of timeline, I think this person wants to know if it is safe to resume normal hospital work 2 weeks from now, or whether we can start bringing patients to our clinics, we can start doing normal elective procedures. Do we have a timeline on this? 2 weeks, 1 month, 6 months?
Once you're asymptomatic, you spend 2 weeks at home and you're asymptomatic, you can come back to work.
Okay. And this another person, they want to know what precautions should be followed to minimize the spread of infection in hospital facilities where there are patients with immunosuppressed conditions. Dr. Abhishek?
I can elaborate on this, but I think I'm going to defer it to Dr. Agarwal. She's a better person than I to answer this question.
Dr. Anuradha Agarwal, ma'am?
Dr. Anuradha?
If she's not,
Hello.
we can.
Yeah. Hi. Can you please repeat the question?
What precautions should be followed to minimize the spread of infection in hospital facilities where there are patients with immunosuppressed status?
Oh, yes. Very, very important question, I think. We need to be very, very careful. We have to take all the droplet and the contact precautions. And I think all the elective surgery, like our hospital is a transplant hospital, we have put all our transplant surgeries on hold. And all the patients who were, of course, your COVID ward or your isolation things have to be totally different from the area where you're housing such patients. And as soon as they get better, sort of, they can be looked up in the home. You need to send them home. And have to be very strict with your contact and your droplet precautions on these patients. And if required be, they can be shifted to the negative pressure rooms.
Okay.
If I may, I think there's something important about this question and the question 2 questions ago. We have to protect the patients from ourselves.
Yes.
In Italy, there's several articles that came out of Italy, and that the
Yes.
true hotspots became the hospitals. And so I think, we're screening our patients, but we have to screen ourselves. And every day you need to go through those questions that you had in one of the early slides about fever, diarrhea, cough, dry cough, loss of sense of smell, loss of sense of taste. We have to screen ourselves, and we have to not be afraid to say, I can't do this today. We're at every door for every healthcare worker that comes in the hospital. They get screened for temperature, and they get asked those series of questions. But we have to ask ourselves as to not only for immunocompromised patients, but for all of our patients.
Thank you, Dr. Hannifin. Next question, it's slightly long. There are 3 questions that almost are on the same lines. They want to know the safety for general practitioners, healthcare workers, surgeons, including dental and ophthalmic surgeons during this COVID times?
Pallavi,
Yes.
I think the entire webinar was on this only.
Yeah.
I mean, that should have been the answer to those questions. But yeah, somebody could take this briefly and put in the bullet points.
Yeah, Dr. Anuradha, ma'am, do you want to take this question?
Yeah, sure. I think very, very important as the question goes, it is the general practitioners. I feel that there should be no normal resuming of normal OPDs. Only very emergency patients, they can consult them over phone. And if in case the patient is really, really sick and he requires admission, he should report to the hospital, to the emergency department, where they ought to be screened first. And depending on their status, to be put as suspected COVID or non-COVID patients, and the care taken accordingly. It's extremely important. I think it's an ongoing pandemic, and we should. I think the thumb rule is that during a pandemic, you take everybody as being infectious, and this is, mind you, a very, very, very highly infectious virus. Thankfully, the mortality rates are not very high, but I think no GP should resume their OPDs until and unless the threat of this virus is gone. And of course, was there any other? Second question was
any specific precautions for dental and ophthalmic people, because they are working very close to the patient's face.
I think it's very, very clear. We are not going to do any elective procedures. No elective procedures at all during this pandemic times. And in case it has to be done, then you ought to be wearing the full PPE with your N95, with your face shields. And mind you, they ought to be just life-saving procedures, because it's not just worth it. It's just not worth it. Our healthcare, the workforce, the manforce is less. We need to conserve it, and so as our PPEs. So it's extremely important to be very, not foolhardy and not very heroic. We need to take everything at its stride and not continue any OPD procedures, any non-emergency procedures. I personally feel that we ought not to be doing.
Additionally, I think the possibility of COVID in asymptomatic carriers undergoing surgery, the fatality is pretty high.
Yes.
So I think that is in itself a very important reason why we should just lie back.
Yes.
Pallavi, I just want to add something here. Just to clarify this, some people might misinterpret. One, a few slides earlier, we were talking about when is it safe to resume clinical work, and then in brackets, it was surgical. I want to point out to anybody who's from the internal medicine or general medicine side here, listening to us, you guys actually see more patients per day. So do not assume that it's the conversation only about the surgeries or procedures, because you have the potential to infect a lot more people. That's the first thing. And you have a potential to actually spread it in a lot of people, because your waiting rooms are always super crowded often. The second part about the infectivity, or again, the technical term, or R0 or R0. Yes, the infectivity is very high and mortality is very low, but I want to clarify that simply by the fact that you're going to have a lot of people infected, the percentage, even though you're saying that there are only, say, for example, 5% people, just putting a random number because that's the ballpark range of all the studies that have come, you're still going to have a lot of people dead. So when we say lower mortality, that's actually a rate or a ratio we're talking about. We're not talking about absolute numbers. You can end up having a lot of people dead, even with a low mortality disease, if it is highly infectious and spreads far and wide in the community.
Yes.
Thank you, Dr. Anuradha and Dr. Abhishek. Dr. Pramod Shinde wants to know, I think it probably came up sometime during the discussion, that why do you need to quarantine surgeons if everyone was wearing proper PPEs during the surgery? I think what he wants to ask is, if everyone was wearing proper PPEs and the patient comes back COVID positive, do we still need to quarantine them?
No.
Dr. Anuradha?
I think if the PPE was proper and every care was taken, those healthcare people do not need to be quarantined.
Thank you.
But do they need to be tested, Dr. Anuradha?
Not really.
Not
No.
really. Okay.
In case they develop some symptoms, of course they can be, but according to guidelines, I don't think there is anything like that.
Okay.
So depending that you've been using your PPE and your fit test and everything is perfect and you're doing the work well.
Yeah. We all hope so.
Anyone? Yes. Do we have someone else saying something? Okay, then we'll move on to the next question. Anyone can take this, whoever is using some form of a telemedicine software for their consultation. Dr. Praveen wants to know if there are any good softwares for telemedicine consultations. What do we have in India? Dr. Aman Goel sir, do you have any idea?
Pallavi, we are using multiple of these, the Practo and all the standard ones we are using. I think they are still in the phase of evolution because none of them realized that this will explode on them. So even the software companies were not ready of the kind of interest that has suddenly come to them within 15 days. So I think we just need to find out our own comfort zone with a software company, and Library, Practo, and all of them are providing this facility right now.
We are kind of using a mix of everything. We are doing WhatsApp video calls, we are doing normal telephone calls, we are using Practo, we are using Zoom, everything. How is it there in the UK, Dr. Neesmart?
So thank you. Yeah, it's an interesting one. We have quite strict legislation around this, particularly with regard to patient privacy confidentiality. And so the generic teleconference, video conferencing software, which is available for free, things like Zoom, FaceTime, and such like, isn't deemed to meet those requirements, so we can't, and that's been a problem. We do have a dedicated system which meets GDPR European legislation requirements, which is called NHS Near Me, and where it's been enacted, it's been extremely successful. The problem is we haven't had the facilities to scale up widely across the NHS. And while some parts of the UK have got very good access to those facilities, other parts it's not as well developed, shall we say. And I suspect the same issues surrounding legislative restrictions like HIPAA are similar in the United States. Todd?
Thank you, Dr. Smart. Dr. Hanniford, is it any different in the US?
We're much like what Neil described. We have to, with 50 states, adjoining states, people who have practices on different borders of states or have a wide catchment, you actually even have to have a state license in the state in which you have a video call with a patient. We would never be able to use Zoom, FaceTime, exactly what Neil described. It has to be approved, and we do have one that we use that's commercially available called American Well. But it has to also go so far. You can only have a phone call with a patient from another state if you don't have a license in that state.
Okay, thank you, Dr. Hanniford. Someone wants to know what is the risk after needle prick injury. Dr. Anuradha, ma'am, can you take this question?
Hello.
Yeah.
Yeah, I think needle prick injury with COVID positive patients.
Yeah.
The studies have indicated that the viremia, or the presence of virus in the blood, is only around 1 to 2%. So there is a theoretical risk of transmission through needle stick injuries as well.
Oh.
But it is low.
Thank you. Another person wants to know how can healthcare facilities manage personal protective equipment supplies during COVID-19 epidemic. I think, Dr. sir, you can take this question. You have been managing this at Max.
Yeah, I think, quite surprisingly, I think the PPE requirements are, as Dr. Raman has also said, that this is changing. 3 days back, things were a little different, and today things are different, because I think mostly the previous PPEs were more for HIV and hepatitis patients, where the mode of transmission was entirely different as compared to the COVID patients. So now we have got specialized PPEs, which has got not only the proper clothing, but also the sealing where you are doing the stitching. So it needs to be properly sealed so that it is completely sealed from outside, which was not really true with the other PPEs which we were using for other infectious diseases. So now I think today the things are little different. Today itself, I think new guidelines have come, and where the sealing has to be very good, and we have to see how and also after making them, they have to be tested well before putting it in the market. So those.
I think Sir's internet connection is a little disrupted.
Yeah.
Dr. Raman, go ahead.
So Pallavi, the PPE supplies is not that big a issue. The problem is the delivery to remote areas. So there are manufacturers in most of the bigger cities, and they are able to supply locally. But because of the lockdown, there is the couriers and the transport facility is a challenge. What IAGES has done is that we have a list of about 70 suppliers across the nation, and we have even put it on our website so that the private hospitals and doctors, they can directly access that list and they can contact these suppliers on their own.
Raman, the biggest problem with the PPE set which are being made in India at the moment are a little different at the moment. I think today itself it has been brought to the notice that the sealing method of joining those things need to be further enhanced, and betterment has to be done. For that, we need the machines, which are not really as many as we would like. So there may be the previous PPEs which are supplied may not have the exact sealing which is required of the joints to make it as a one-piece suit.
Yeah.
And sir, are we also dealing with affordability issue with various public hospitals or private hospitals in terms of PPEs?
Yeah, well, as I mentioned before, as far as the PPE sets are concerned, the equipments are concerned, the masks are concerned, anything which is concerned with the medical team, I will be the last person to compromise on the cost, the quality, or whatever it is. If we don't have a PPE set, we will rather refuse a patient to be handled rather than putting our team and medical and paramedical staff into, because it's really not worth it, as we have said. So if we don't have the proper equipment and set, it's better rather not to deal with such patients rather than sort of put ourselves into risk.
I think there's also one other important point with that. If you look at how institutions are managing PPE materials like the N95 masks, they're recycling them, sterilizing them with infrared. There's a study from one institution about hanging them in an oven at 158 degrees so you don't injure the mask, but you kill the bacteria, or just putting them in a paper bag and leaving them there until you think the actual virus that has possibly contacted the mask will have died. And there's just not a lot of data around that. I think one of the reasons to push patients off is that the industry now is really geared up and on a large scale making N95 masks. So it's not like, I don't believe that we'll actually be running, I don't believe we will be running out of them. We'll actually have more resources later to operate on patients.
Well, I quite agree with you that because with the passage of time, possibly we will get that time to have more masks made and more PPEs made and made available to the surgical and medical teams.
Thank you, sir. We have 2 or 3 more questions. One from someone whose name is not there. How are we planning to manage the relapse of this outbreak if it occurs on a large scale? Dr. Neil Smart, you are involved in the planning in NHS. Do you have any insights on this? Are we being prepared for some form of a relapse? And if yes, how?
Certainly, people have talked about cyclical nature of the relapse, and particularly again in the winter time for us. So we're looking at from November, December, January at the end of 2020. I think it will come down to how we organise healthcare services and when we start some of the removal of the restrictions. We're currently under lockdown, and that's going to happen for at least another 3 weeks. We still don't know when schools are going to come back online and when we're going to start seeing life return to normal. But I suspect that we won't see complete lifting of all restrictions for some time, and particularly for our most elderly and most vulnerable. There have been discussions about keeping those over the age of 70 under lockdown for even longer, possibly 12 months. It's been reported in the past 24 to 48 hours to help mitigate some of the spread and some of the risk and the overwhelming of the health service. So, long time to go.
Thank you, Dr. Smart. I think those are all the questions we have for now. Can we go back to Dr. Baig for the key points and summary of this discussion?
Yeah, so thank you, Pallavi. I think we'll just wrap this up now. It was a wonderful discussion, and I think I've been receiving lots of messages on my. 1 second, please. Am I sharing my? Yep. There we go. Can we see my slides here?
Yeah, we can. You'll have to put them in slideshow mode.
Yeah. Right. So here we go. From the IAGES webinar today, the summary points that we could accumulate, and I thank Dr. Pallavi for making it. Testing, and more testing. It seems this is the way forward. Plenty of areas where you need to test. Many areas you don't need to, but it does look like for the hospital staff, for the patients coming into the hospital, and prior to surgery, there seems to be need for doing more testing. Hospitals are hotspots, as Dr. Todd Hanniford has been saying, for COVID transmission. Admissions and visits should be minimized as much as possible. Doctors and healthcare personnel who attend patients in the OPD or ER should wear protective gears, and as per Dr. Anuradha Agarwal, gloves, an apron, face mask should be good to protect you in the OPD. All elective and emergency surgery patients need to be tested. Again, back to COVID testing. Looks like there's no consensus on routine testing of the healthcare staff, but it looks like in some hospitals it will become desirable and routine as well, if the resources permit. In the absence of COVID status, all surgical patients need to be treated and assumed as COVID positive, just like HIV and universal precautions. Still, the report is available. And while rapid antibody testing may have some role, it still isn't there. According to Dr. Anuradha Agarwal, I think we're still doing RT-PCR as our tests. CT thorax can be added, as Dr. Abhishek said, if a CT abdomen or other region is being done. Dr. Neil Smart also said if he was going to treat a cancer, he would add a CT thorax. All surgeries are to be done with full PPE and minimal number of OR personnel. And PPE specifications are around, and newer regulations are being given in India, so we need to just pay attention to them. And HIV PPE, as according to Dr. Abhishek, can be used for COVID if you can do the gown and the footwear and you just have the N95 respirator. It would do. A face shield or a visor, an add-on may even be helpful, more helpful. And according to Dr. Todd Hanniford, use laparoscopy only when there's significant morbidity involved with open surgery. Otherwise, avoid laparoscopic surgery. It's an unknown territory that we are treading on at this moment. Dr. Chaube said the consent stating the risk of contraction of infection may have a role in protection against the possible litigation, although it is a little unclear, but so far we should not be worried about that. All COVID positive patients are to be transferred to a COVID hospital in India. And if you diagnose them after admission, to a COVID wing and isolation ward. Steps are being taken by the government of India to minimize the impact on economy and employment of the doctors who are now the frontline warriors in this crisis. And that's some incentive and some comfort. Healthcare personnel are at a significant risk in regards to the physical and psychosocial health. So it's not only about getting COVID positive, it's the daily emotional trauma that a doctor is undergoing at the present moment. And I think many of us would need some support, counselors, if possible, also at some times. We are I think most of us agreed that we are looking at a timeline of 18 and 24 months based on past experience, with multiple peaks at different times in different parts of the world for this COVID crisis to go away, the flu to go away. Of course, we will see abatement. It will regress. Therefore, it doesn't mean that we have to be locked down for 24 months. All it means is the flu wave will go away in entirety in this time. But in a few weeks or few months, we should be back to near normalcy based on what happens. It's a very fluid and dynamic state, so we can't put a finger on a particular number. And the ongoing COVID crisis may bring about some permanent changes in the healthcare system. Some of them may actually be good, like routine hygienic practices like hand washing may be something which will go up. We will also probably be better prepared for plenty of things in future. So I think everybody in the panel, and especially Dr. Todd Hanniford, pointed out so many positives that will happen because of this crisis. We'll get stronger with more difficulty. And that was what it was. And I would like to, again, thank each one of you, the panelists, for taking up this time. It's been 2 hours, and it's been really great to have you over. I thank the IAGES. I would like to thank Dr. Raman Goel for this initiative. I would like to thank Dr. Pradeep Chaube, Dr. Todd Hanniford, Dr. Neil Smart, Dr. Abhishek Kumar, Dr. Anuradha Agarwal, and Dr. Pallavi Priya also for your time. I thank you all. I hope you all enjoyed. We hope we have answered your questions. If there are any more, you could always take it on our chat room, and we could address them later from the IAGES Facebook page, where it has been screened simultaneously. So thank you, gentlemen and ladies.
Thank you.
We will leave you on this note. Thank you once again.
Thank you.
Thank you. Thank you. Thank you so much.
Dr. Raman
Thank
Goel,
you,
would you like
everybody.
to say anything now before we leave?
Okay, I think you have summarized very well, Sarfaraz. If I have a minute, then I would say RT-PCR is the only test that can show infectivity of patient. So let there be no ambiguity about antibodies versus RT-PCR. RT-PCR is the only test that shows infectivity of patient if you need to do it. A lot of hospitals got shut down, not from the COVID patients, management of COVID patients. They got shut down when they were managing asymptomatic patients. So I think if we manage every patient as COVID patient, as somebody rightly asked that question, then you don't need to shut down these hospitals. Your staff will be safe, you will be safe, and you don't need to fumigate or sanitize the hospital. So I think these are broadly 2 points. And one last point, the government is very insistent that the family physicians should keep their clinics open. I think it's important to realize this disease is not going to go away soon. By asking doctors to close their clinics is not fair, because these are the people who are the gatekeepers of healthcare system. Lot of people like doctors and nurses are managing COVID patients in the ward. So if a family physician can manage a patient on an outdoor basis with proper social distancing and hand hygiene, they would be safe. So I think we need to, even the medical community need to look within. So we have triaging system where respiratory patients don't come to family physician, and family physician sees a patient with a little distance. And if they are, and with basic hygiene like a surgical mask and a glove and a goggle. And if they have to examine a patient, and if there's a patient with a respiratory problem, obviously they need to use a N95 mask. So I think these are the issues which are important and which will be probably taken up in another webinar in future. I wish to thank Dr. Anuradha Agarwal, Dr. Pradeep Chaube, Dr. Todd Hanniford, Dr. Neil Smart, Dr. Abhishek Kumar, and obviously Dr. Sarfaraz Beg, who conducted so well, and Pallavi, who is always by his side to support. So thank you so much. It was a very informative webinar, and hope to see you all again.
Thank you so
Thank
much.
you.
Thank you.
Thank you.